The faces in third trimester on 3D are really so different that you can recognize the face of the father or the mother, and they are very typical. But in early gestation, the faces really look very, very similar, so you cannot recognize, let's say, similarities to anyone, but you can recognize severe abnormalities. So you can use really 3D to recognize gross anomalies of the face. But we have learned today that what you have to do when you look at the face to examine systematically like every other organ. So what we are doing in general is when we look to the nuchal translucency, we are looking to the face as well. And in addition to the nasal bone, we can check the facial angle as a hint. And of course, we'll do it automatically to check the profile and the head shape. And when I see the mid-sagittal view, I turn the transducer 90 degrees to get at least 3 planes. The one in the level of the eyes with the process maxillaris, the other one in the level of the maxilla, and then tongue and mandible are the 3 images I like to do. And then if you are using 3D here with the volume, you can place the lines that you see, the 2 orbits with the lenses, the maxilla and the tongue, and you can do another one in the level of the mandible. So this is an approach. This is why the parallel planes are important, but you can also go from anterior to posterior to have a kind of coronal plane or slightly oblique planes. With the coronal plane, you can see both eyes and lens, and the oblique plane, you can get the so-called retronasal triangle Valdo Sepulveda described, and I will discuss this slightly later. And if you look at the face like this, you can very nicely see the eyes and the orbits. And I was very, very surprised that in the guideline of EasyWalk, it is written that optional, you may also look at the lens, because there are very, very, very rarely diseases affecting the lens as cataract if you don't have a high-risk pregnancy. So, but it's written in the guidelines that you know that you can see these, but almost always you will have normal findings there unless you have other severe additional abnormalities. And there is no evidence that you see it in early gestation as an isolated lens problem. This is a very good and nice view that you have a frontal view to the face, kind of coronal. This is the typical eyes in anencephaly, and these here are typical for holoprosencephaly with some hypothyroidism. So one of the hints you can use at this stage is if you don't have a nose, because you have arynia or other disease, you don't have these white dots at this level, and you have very narrow eyes. In hypothyroidism, this was also in holoprosencephaly, as you can also recognize in this part. And you see here a frontal view to the face in a fetus with holoprosencephaly. The eyes are a leading sign that they are severely abnormal. In this view, you don't see even eyes, and they may be microphthalmia as well. Profile is abnormal in almost all cases with the severe allobor holoprosencephaly. And if you want to use the multiplanar view, you can demonstrate from anterior to posterior the process maxillaris, the maxilla, the orbits with the lenses, and then the falx cerebri. And you see here an abnormal case, the abnormal shape of the head, and here you the holoprosencephaly and the abnormal eyes as well. And if you do rendering, you can see the difference between a normal baby, and you see even the abnormal ear, and the profile is ugly. So we heard today in the talk on of Gustavo before on the face predicts the brain, and this is something you can use in first semester as well. And the disease before showed by the colleague, where you have seen the nose, I assumed it is a sebocephaly because this was what we can see here, and this is a kind of severe abnormality. You have instead of the nose this tube, and this is something you can see here. You have a single nasal hole, and this is what we saw here, and you can see it even later in gestation. The cases we saw were isolated like this, plus the holoprosencephaly, of course. I haven't never seen these 2 noses before. And there are cases of cyclopia or pseudocyclopia with the proboscis. In the cross section, you can see these fused eyes. In a plane slightly higher, you see the proboscis here, and you can see on a video clip here the transition from this plane to the other one. and you see the finding of holoprosencephaly. So when suspecting holoprosencephaly in early gestation, check the face or vice versa. If you have an abnormal facial feature, check comprehensively the brain to rule out holoprosencephaly. And this is here one case of proboscis, as you see. And I show another case here with the one you have seen before with the pseudocyclopia. This is a rare case, gave me to at 10 weeks. We see the anterior cephalocele, and this is something where you try to look at the face, you will see it obviously as early as even earlier than 10 weeks. I will not discuss about the nasal bone. Katya did it very nicely 2 days ago. But we'll go now to one chapter on retrogradata and macrogradata. Retro means a small mandible. Retrogradata means it is pushed postward, and the macrogradata it is small. Until now, what I was doing is when I look at mid-sagittal view in general, the mandible, the true mid-sagittal view of the mandible is only one dot. This is slightly oblique. And it reaches, in general, the maxilla, and the line between them is at the same level. And if you have a macrogradata or retrogradata, it is at the level of the half of the maxilla. So you see here, it is not anterior, but it's at the half of the maxilla. But please, you have to be careful. Of course, you need to rule out other things, but many fetuses appear so severe in gestation, but they are more mild later on. It seems that the mandible grows so rapidly, and the image is not as severe as you can see it in early gestation. So these are other cases, unless you have additional signs, because these Pierre-Robin appearance may be found also in genetic diseases, also in trisomy 18 and others, so be careful. And one of the approaches which are very nice, and I want to spend a few minutes on it, is provided also by Valto Sepulveda. He was saying, once you are looking to the eyes, go a little bit anterior, and you see the retronasal triangle with the processus maxillaris and the maxilla. And if you look at this plane, this is the paper he wrote on the retrogradata. He said, in this plane, when you see all these together, you are cutting anterior to the mandible, and this is why there is a gap, physiologic gap on the mandible, where in cases of retrogradata, you don't have this gap. I'll show you what is this approach. So imagine now you have this nice profile, and you are cutting in this plane to see the nose and the upper maxilla. You are behind the tip of the mandible. So this is why you see the left and the right side of the mandible, and you see the normal gap between them. If you have retrogradia, this is here the view. Look, now this is a video clip rotating from the anterior, and you see here 1, 2, and you see that underneath you have here a gap. If you have a retrogradia, the line where you will see nasal bone with the processus maxillaris is just anterior to this part, and then you don't see the gap because it is behind the line C. So the absence of the mandibular gap is for him a sign of retrogradia. That means you are confirming in a way this approach, and he showed us that the line may be of importance, and the idea was taken by the group here from Tübingen, where they showed that you can use this line as well to measure a distance, because this is a kind of impression, and this is the paper. I will show you later on the paper published by Hoffman, and there is another paper by Katya and her group appearing soon. One main message, please, if you don't find anything, if the ears are normal, everything is normal, be careful, because wait a little bit before telling, oh, this is bad news, because many cases appearing so severe may be less severe at gestation. So this is a video clip you see here at 12 weeks, transabdominal. And this is the same fetus later on, 26 weeks. Of course, you see the mouth downward, and you see it here, but it's less severe than we assumed in early gestation. So the lady came back this year and said the baby is fine. They had the operation of the palate, but she's very happy and so on. And when I saw the first picture in early gestation, I said, my God, it's going to be a very severe form. It's not true. The mandible is growing more than we expect, and this is why give this baby a chance if it's isolated, because they have excellent outcome. And sometimes one of the parents tell you, yes, my husband or me had a small mandible when we were born. So this is the paper published by Hoffman and a co-worker. And see, they draw a line and measure here, and you see in micrognathia the distance is larger, and in other cases, especially in cleft palate, it's also anteriorly shifted. Now I come to the second part of my talk, and the longer part, which is what we heard a few days before on the cleft in the early gestation. So cleft lip and palate are a common condition. It is between 100 to 500 to 1 to 1,000. It is associated in 20 to 52% of the case with other abnormalities. And if you look at the anatomy, you have the primarily or anterior palate with the alveolar ridge, and you have developing from lateral, the secondary and posterior palate part. This part develops with the face, with the nasal, with the nose, and with the eyes. This is why you'll find abnormalities on the middle part like this, especially in holoprosencephaly and severe chromosomal aberrations. But both parts may be affected in mediolateral or even median cleft palate. So what we have in addition, we have the raphe, which is the region where both fused, and we have at this region the foramen incisivum. Actually important, because probably this is the region having latest ossification, and this is something which can lead to false positive results. We have to know that during embryology, the ossification is finished around 12 to 13 weeks, so we may have a delay ossification in few children, but all cases having cleft palate, they have also an affection of the anterior part. The exception is the soft palate and uvula may appear isolated. This is another mechanism. So if we look at the different spectrum of clefts, and this is here a scheme done by Gianluigi, we have the mediolateral one, we have the bilateral one with protrusion, we have the bilateral one without protrusion, and we have the median CLP without any alveolar ridge, as you have seen in cases of holoprosencephaly. And what we have learned until now on the maxillary gap is you can have a look either, and this is what we are taught to do, either a kind of coronal or frontal view where you see the nose with the upper lip and the mouth, and you see here the cleft with the deviation of the nose, or we can have, in addition, a kind of axial view to the upper maxilla with a gap here obviously seen. But on the other hand, we were also taught that if you want to check the profile may be misleading. This is why you may not see it, because here the profile may be normal, in the exception of cases where there is protrusion. And this is why we were discouraged to look at the profile as a screening tool for maxillary, let's say for cleft palate, and the other view was or is very important. So in the year 2010, there were two interesting papers. The one was by Valdo on the retronasal angle, as you see here. And he was writing down what we're doing every day, this frontal view to check the maxilla. And I still believe that this is the best plane to check for cleft lip and palate, of course. But as I was saying this morning, if you are asking people to do additional planes for one disease, the uptake may be difficult, and this is why we should make it even easier that the people have a hint to look for something different. Another paper in the same year was published by Lukas Wilhelm. He's in Germany one of the specialists on this field, and he described that if you want to check for a cleft palate, you can have a look even in the mid-sagittal view, because you see the posterior part of the cleft like this. And I saw that in your bags you have from one company advertisement leaflet where he's showing the different parts of this. So this is his paper, and this is a good idea. And since then we started looking in the mid-sagittal view also to the palate, and this was obvious to do the same early gestation. So if you look at here again to these images, you see then that these fetuses, they have here an opening, but we never looked at it this way because we see it the other way easier. In other words, we're saying, do we see the maxilla in early gestation? The advantage is that we don't have ossification of the face, so we can from different angles see the maxilla. Yes, we are seeing very well the maxilla, because once we are checking the nasal bone, we were taught to go from one processus maxillaris to the other and to observe here that the nasal bone is present not where the process was, but exactly between. But what we are doing here, indirectly, we are also scanning or screening the maxilla in this sagittal view. So what you are doing here, you are not only looking at the nasal bone, but you are screening also the maxilla. And this is why the hypothesis was that in cleft lip and palate, in the mid-sagittal view, between 11 and 14 weeks, you may have a maxillary gap, a gap in the maxilla showing that there is a cleft lip and palate. So the theory is like this. It depends if you have a protrusion like this. We are almost never in a true mid-sagittal view. So if you have such an oblique view, you will have a protrusion. You see here the anterior part, and you have a gap, and you have a posterior part, or you may have only anterior part seen and something absent behind. If you have some median cleft, you don't have any maxilla seen in this plane. And so you can imagine how the other combinations can be. So this one or that one without the even without the anterior part. So the possibilities of having abnormal images in this plane is possible or likely depending on the size of the cleft. So this is why if you look at now the images, you remember this fetus we saw this morning, you see the gap is here, and if you take this one, the anterior part is missing. You never have a nasal bone without process maxillaris and where there's no part of the maxilla here. But if you didn't look at this region, you will never see it. You will discuss with me that this NT is not very well done. So, and this is here, when I showed this to John Heights, I'm really interested in these fetuses having this skin edema until the nose, but you see here there is also a gap with an abnormal position of the alveolar ridge, and here also a half missing of the maxilla, and here the anterior part missing as well. So you can take your old images and don't focus on the nasal bone or on the posterior fossa, but now look at these conditions as well. And now, once you see these things, you say, okay, what is the detection possibilities of these conditions? So we did with Kypros a study where in our center and 3 centers in London, we took all cases having CLP after having had a first trimester nuclear translucency, and in comparison to the Singelaki study, let's say we are more or less good people doing good scan even in the different centers. So there were 50 in group 1, 50 cases diagnosed in first trimester, and there is a group 2 of 31 fetuses having had the first trimester but not diagnosed at this stage. And if you look at in these cases, of course, majority was associated, like trisomy 18 or trisomy 13, or having other diseases, and the fetus was scanned accurately. But in isolated cases, if you are not doing systematically the retronasal triangle, you may miss it. And I'm not unhappy that some cases are missing, but this is not the issue. But let's say if you're doing a good scan, actually you want to be very good and to detect everything. But interestingly, that 31 cases was not diagnosed, and 3 had associated, but the majority was isolated. So this one had some mild things like single umbilical artery or VSD or so on. Now, in other words, the detection rate of this in this center was not 5% like Singelaki. It was 24%, which could be improved. Now, what we did, we took the images of all these cases retrospectively, like we did at that time with the nuchal, and we took also one-to-one comparison with the so-called normals, and to find out if there is a bias, and we measured the size of the gap, and the maxillary gap sign was present in the whole population of the isolated one in let's say roughly 2/3 of the cases. In these cases, in almost all, because they were large, and also because if you have an abnormal cases, you have a lot of images. If you have normal case, you don't have a lot of images of the face. But interestingly, if you do your work until now, you have 1 every 4 case you will detect, but using the maxillary gap, the potential is at least 2/3, and I guess it can be slightly higher if you're looking more targeted. And this is when I was discussing this with my colleague at work. But she said, but we see it every time very well. I don't think that it's worth to do it. I say, okay, I take a case of yours, detected at 22 weeks, and you didn't see it in the legislation. The nasal bone was nice. And look at here. And she said, but I did the retronasal triangle. I didn't see anything. But I said, look at this image here, where you measure. there is half of the maxillary is not there, and this is something I show. You can see it posteriorly, and this is why when you return home, take 5-6 cases not seen in early gestation, and look at the images. You may find on this and that some part of the let's say of the maxillary gap. So the sign should be easy. This is how I learn doing things. I take a volume and I learn on a volume to move from left to right, from the processus maxillaris across the maxilla to say what is the potential of which plane. And you see here in this in the next image, you see here you have a maxilla, but you have an absence here. If you look at this plane, you see exactly the scheme I was showing you. Because I put the line here, we have anterior part, but a gap here, and this is the gap seen between the cases. So this is the volume of a cleft at 12 weeks plus 5. So I showed you the signs I saw since the early 90s, and we have a new sign of Gustavo of the brain. This here, a typical false positive risk. Be careful when you are scanning in early gestation, transvaginally, because there we may have exactly this region, the anterior part. You have a kind of gap. This is by sure a delayed ossification. And if you look at, let's say, a specimen from embryology or anatomy, you have exactly at this region between the alveolar ridge and the palate here a kind of between the raphe and the ossification center, you have here the delay of ossification. And let's say all of these cases were less than 1.5 millimeters. So people may ask me, yes, but are you not worried about false positive? You know, this is a hint. But if you see this, you turn the transducer, you have to see in the anterior view if you have a normal maxilla, and then that's it. You don't need to be worried, because it is unlikely that we detect large defects present here, but the alveolar ridge is normal. So this is a hint, and if you turn back to have a frontal view, you will see anyway the normal maxilla. So the limitations is, of course, that this is a hint and it's not a diagnostical tool. So this is why you have to get a coronal plane. If we know that there are a delay of ossification, and this is why it can be apparent on ultrasound, especially in high resolution, as a maxillary, as a small gap, not the large one, not if the half is missing or the anterior part. I think the sensitivity is going to be around 66%, because this is what we had. Let's go for 80%, but not for the very small one, because the very small one you will not get in this plane that it's so large that it can be seen. But it's fine, because we are more interested in the larger one to have diagnosed, not in the small lips or small. And of course, we can, especially for such a disease which have a good outcome, we are, of course, aware about the issue of the ethical issue, because some patient, and you see here, decided for termination of pregnancy. So this is something I know, but you know, this is what we had in transposition and other disease. So this is the other side of the medal of early detection. Everyone have cases of gastroschisis terminating at 12 weeks where they have very good outcome, and so on and so on. But this is why we cannot stop doing science at this stage. So this is my favorite image, because today we have discussed many things, but yesterday and today we've seen that nuchal translucency, even in the era of NIPT, can be used not only for aneuploidy but for heart defects and more than 100 anomalies. We can look at the angle, which is increase in trisomy 21, but it's decrease in spina bifida, I showed you before. And we can look at the IT. I discussed this morning, because the IT is compressed and abnormal in spina bifida, but it's enlarged in cases like chromosomal aberrations and the Dandy-Walker or Blake's pouch cyst, or let's say something to be controlled. And there's a bone for aneuploidies, and the maxilla, which can be also a hint for the gap. So this is why when you go to the tube, mind the gap, not between the train and the platform, but between the nose and the nuchal translucency. Thank you.